Trauma-informed care. The facility must ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. Patient-endorsed or family chart indicate a history of past trauma experience which may place the resident at risk for unintentional re-traumatization and negative emotional, physical, cognitive, behavioral reactions such as feeling anxious or fearful, avoidance of activities and social support, refusal of care, ADLs, physical, occupational therapy, irritability, anger, increased depression, anxiety, sleep disturbance, appetite disturbance, increased fatigue, or negative verbalizations. Residents who have a history of trauma and or PTSD, post-traumatic stress disorder, must receive appropriate person-centered and individualized treatment and to services to meet their assessed needs. There are screening tools such as questionnaires, assessments, checklists, etc. to ensure proper information is collected in order to care for residents appropriately. Acute versus chronic trauma. Acute, weeks to months. Adaptive, keeps person vigilant and reactive to danger, resolves as safe environment is established. Chronic, extended period to long life affliction. Maladaptive stress response to everyday events, alters daily patterns, maladaptive coping responses, persistent symptoms, flashbacks, physical and emotional symptoms, avoidance, fear, and isolation become frequent experiences. PTSD is not exclusively a sequence of combat or war zone exposure. Individuals who have been physically or sexually assaulted, who have experienced a terrorist attack or natural disaster, among other things, may also be affected by PTSD. Some older nursing home residents may have lived through a time of genocide and witnessed or been subjected to the intentional and systematic destruction of a racial, political, or cultural group, such as that which occurred during the Holocaust and World War II. Being admitted to a SNF can, which is a nursing home, cause worsening or reemergence of symptoms, trigger memories of traumatic events, and coping with these memories may be more difficult for older adults due to the structured environment. PTSD symptoms can change with age, changes in role, functional loss, cognitive decline, emotional regulation, environmental changes, stress, re-traumatization, failure of existing coping strategies, GDR, etc. Care planning, signs and symptoms, history of trauma, PTSD, distrust, fear, depressed, anxiety, aggression, angry outbursts, tearfulness, agitation, trembling, cowering, panic attacks, withdrawal from social interaction, and changes in sleep pattern. PTSD, re-experiencing, reliving the event, emotional behavior expressions or distress, outburst, irritability, discontent, inability to experience pleasure, disassociation, hyperarousal, increased startle response, difficulty sleeping. Care planning interventions. PTSD is associated with anxiety. Utilize aerobic and non-aerobic exercise, meditation, yoga, progressive muscle relaxation, antidepressants, adrenaline blockers, psychosocial services, and minimize or eliminate triggers. Be aware of your tone of voice and body language, and approach should be calm and direct. Monitor and provide ongoing assessments as to whether the care approaches are meeting the emotional and psychosocial needs of the resident, along with reviewing and revising care plans. One example of past traumatic events can be Korean War, veteran, Army, infantry, or direct combat exposure. Triggers can be loud, unexpected noises of unknown origins. Symptoms and behaviors can be persistent yelling and anxiousness. Interventions, Prevent loud noises. Utilize noise-reducing blocking devices. Put on a television, radio, white noise machine, earplugs. Place resident where they visually see the cause of the noise and prepare the resident in advance that loud noises will be occurring. Coping skills, drinking coffee, sitting outside watching television or listening to music. Staff response and care approaches. Explain the cause of the noise and show them. Approach in calm manner. Allow resident to express their feelings. Offer noise canceling options, headphones, earplugs, TV, etc. Offer a quiet place. Encourage relaxation techniques. Provide support and reassurance of safety and security, and offer interventions and activities to increase sense of control. Social service referral, psychological services, and psychiatric support services. Another example of post-traumatic events can be past sexual assault abuse. Triggers can be unannounced, unexplained touching during care activities, staff treatment providers touching residents without permission, resident feeling there is insufficient privacy during ADL's cares and treatment procedures, disrobing for medical treatments, receiving physical examinations by male providers, some same-sex as perpetrator abuse. Symptoms and behavior. Resident refusing certain care procedures and treatments. Increased anxiety. Resident report of increased somatic symptoms, pain or fatigue. Increased heart rate, shortness of breath. Increased irritability. Interventions as available. Use female direct care staff and rehabilitation staff. Ask permission to begin care for ADL care and medical treatments. Encourage and allow resident to provide safe self-care and hygiene care as much as functionally, physically able. Use hand over hand, etc. Offer window side of window or increased privacy. Coping skills. Guided breathing, mindful meditation, prayer, distraction, watching television, especially game shows, reading the newspaper. Staff response and care approaches. Reorient to activity, care procedures. Explain care procedures step by step. Approach in calm manner. Allow resident to express feelings. Offer a quiet and private place to calm down. Encourage relaxation techniques and activities to increase sense of control. Social service referral, psychological support services as indicated, and psychiatric services as indicated. Questions. Question number 1. True or false? Anyone can experience a traumatic event. Question number 2. Types of traumatic events include A, physical sexual abuse, B, natural disasters, C, wars and historical traumas, D, accidents and injuries, E, significant losses, F, all of the above. Question number 3. True or false? Being transferred to a skilled nursing facility in and of itself does not constitute a potentially traumatic event. Question number 4. PTSD stands for A, physical therapy for speech disorders, B, person-centered treatment for sickness and disability, C, post-traumatic stress disorder, D, psychological treatment for symptoms of depression. Question number 5. Core principles of trauma-informed care include A, safety and security, B, trustworthiness and dependability, C, fostering collaboration and sense of empowerment, D, all of the above. Question number 6, true or false? Re-traumatization refers to the process of re-experiencing traumatic stress as a result of a current situation that mirrors or replicates in some way the prior traumatic experiences. Question number 7. Examples of potential re-traumatization triggers include A, loud noise, B, supporting sense of privacy, C, casual touches, D, offering choices, E, A and C, F, none of the above. Question number 8. True or false? Trauma-informed care plans should be person-centered and idealized. Question number 9. Staff can support trauma-informed care by A, learning a resident's history and life story, B, preventing trauma triggers and unintentional re-traumatization, C, approaching all residents in the same way, D, all of the above, E, A and B, F, C only. Question number 10. Trauma can negatively impact a person's A, emotions, B, physical health, C, cognition, D, behaviors, E, all of the above.